Welcome to the Medical Association of Georgia's award-winning Top Doc Show. With more than 8,000 members who care for patients in every specialty and practice setting, MAG is the leading voice for physicians in Georgia. Go to mag.org to join MAG if you're a physician in Georgia. And thanks to MAG Insurance Agency for its support as a sponsor.
Welcome to the Medical Association of Georgia's award-winning Top Doc Show. With more than 8,000 members who care for patients in every specialty and practice setting, MAG is the leading voice for physicians in Georgia. Go to mag.org to join MAG if you're a physician in Georgia. I'm Jeremy Bonfini, the Executive Director and CEO of the Medical Association of Georgia. Today, I'm joined by Dr. Suneel Katragadda. Dr. Katragadda is responsible for the clinical supervision of the Child and Adolescent Services at Peachford Behavioral Health System. He received his medical degree from Gunter Medical College in India, and Dr. Katragadda received further training through an internship at the University of Alabama School of Medicine, where he completed his residency in psychiatry and fellowship in child and adolescent psychiatry. Dr. Katragadda is a board-certified physician in general psychiatry and child-adolescent psychiatry. He is a member of the American Psychiatric Association, the AMA, the American Academy of Child and Adolescent Psychiatry. And prior to coming to Peachford Hospital, Dr. Katragadda served as the medical director for Avita Community Partners. Welcome, Dr. Katragadda.
Thank you.
Thank you. In today's episode, we'll be discussing tardive dyskinesia. Dr. Katragadda, can you tell us how it impacts a person's life?
It has a huge impact. Tardive dyskinesia is a abnormal movement disorder that comes from taking antipsychotic medication or something similar that blocks a particular chemical called dopamine. So it starts out with a very simple, benign movement, something like a blinking or rolling tongue or squinting. And then as time goes on, it becomes severe and severe to the point where, people can't walk or people can't hold the fork or can't do the chores, can't go to work. So the impact is huge as it gets severe.
Great. Why is routine screening for TD so important, especially for those taking antipsychotic medications, and how often should it be performed?
So the routine screening is very important because initial symptoms can be very subtle and can be easily missed. Because if you don't have it in your mind and you're not looking for it, you don't see it as an abnormal movement. So you may think it's as an abnormal movement. And the problem is sometimes the patients themselves are not self-aware, so they don't complain. We have a tendency that we don't necessarily bother if patients don't complain. So that's why I kind of lose-lose. As patients don't complain, you're not looking for it, so it's easy to miss. That's why routine screening should be a standard, so that way it will be performed every single maintenance visit.
Great. Who's at higher risk of developing TD? And are there certain patient populations that providers should be particularly vigilant about?
Exactly. Scientifically, we don't know for sure who develops, who doesn't, just like a cancer and smoking, who don't know who gets it, who doesn't. So there are some risk factors that might help us. In terms of patients, older, female, postmenopausal, they are at higher risk. And also people who take older generation antipsychotics are at higher risk versus new generation antipsychotics. And people who have a mood disorders like a bipolar or depression, they're at higher risk. For example, people who also have autism or other developmental disorders, they also get prescribed those antipsychotic medications. They are at higher risk. So if we can remember those demographic groups, I think that might help us at least identify the high-risk patients.
Great. And what makes TD different from other movement disorders that providers might see? And why is it so challenging to detect without routine screening?
But it is a challenging because, like I said, it's a very subtle initially. It can be ignored for a while until patients themselves complain, and then they have some impairment, can walk or can eat or can hold the fork. And at that point, you have a lot of impairment, both socially and occupationally and also physically. So it's important because it could be irreversible or permanent impairment if you don't treat in a timely manner. So that's why it's important to screen as early as possible and catch as early as possible and treat with the right kind of medications, because there are medicines that are very effective and they're available in the market for the last 5 years.
Right. So it sounds like you can catch it early and address it, but what's the gap between what providers know about TD and how often they screen for it? Is there a lack of awareness amongst the provider community?
It's not like they necessarily unaware of the TD or tardive dyskinesia, but tardive dyskinesia is oftentimes not put as a priority in a lot of protocols and routine maintenance visits because it's not a common thing. For example, if you take older antipsychotics, 30% of people develop tardive dyskinesia over a year. If you take a newer generation of antipsychotics, you're about only 7% of people develop tardive dyskinesia. So 93% of the times don't, but 7% is still a lot. But a lot of times we focus a lot more on the commonly occurring side effects and discuss those with patients, but oftentimes we don't spend time on things that don't happen to everybody.
Right. So how do you talk with your patients about the risks of TD when starting or continuing antipsychotic medications? What makes those conversations difficult or even empowering?
It is important for all of us as a providers to remember to discuss both commonly occurring side effects and also side effects that could happen not as common. For example, tardive dyskinesia is one of those that doesn't happen to everybody. Like I said, if some of the newer generation, fortunately, have a lower risk. It's only 7% on average develop tardive dyskinesia. So it's important to discuss pros and cons and the risk benefit discussion when you're starting antipsychotics. As I said, we identified some high-risk patients, especially if you see some high-risk patients, it's important to bring it up. That could happen to you. You are in this possible group of patients who could develop a lot more than an average person. So that way they can look for it. I would put it in a way that, hey, you or your family or friends notice some tick-like movements or something that's happening, and please let us know. So we need to look at it because it could be problematic if you leave it alone for too long. And the good news is there are good treatments for it now. We did not have treatments for 70 years. Luckily, we are at the time in the world where we have two effective tardive dyskinesia medications in the market. So the question is to get the diagnosis in time and also getting on the right treatment in time. So that way you don't have a long-term impact in your physical function or psychological function or even your occupational function.
Great. Are there particular care settings like primary care, long-term care, or community mental health where TD screening could be improved the most?
Yes, so I think each setting has a different set of issues. In generally, primary care setting, we focus a lot more on other side effects that happen often, like a weight gain or cholesterol going up or triglycerides going up, or you have any other diabetes screening or blood pressure. We focus a lot more on the maintenance visits in primary care setting. So they don't have a routine screening for tardive dyskinesia as much as a part of the EMRs or part of the algorithms or guidelines. But in a psychiatric setting in a mental health centers, there is a different set of problem. We do have a very good, robust screening protocols in mental health centers, for example, and provider manuals say clearly that, TD should be part of your routine assessment for every maintenance visit. But the problem is there is not as much focus on the treatment part. Imagine there are about 800,000 to 1 million people with tardive dyskinesia in the world. There only 50% get diagnosed, and there is only 10% get treated with
Hmm.
right medications. 90% of patients don't get treated. Can you imagine any medical condition like a diabetes or high blood pressure? We treat only 10% and don't treat 90%. You don't have anything parallel to any specialty. So that's why there is a huge gap, and we all have a lot to work on in identifying and diagnosing patients in time and also getting them on the right medications. Provider manuals with the community mental health centers need to be updated and put more emphasis on not just screening, but also on the treatment. You have to get to the next step, right? So if you don't treat them with effective medicines that are available, it's no good even if you're diagnosed. So there are a lot of patients falling off even between diagnosis and treatment. And there are a lot of people falling off, people not getting diagnosis to getting diagnosis.
Right. Yeah, that is a very surprising number. So, what role do you think policy, government policy, or healthcare systems can play in making TD screening part of a standard of care?
So I think it's like I said, in community mental health centers, maybe Department of Behavioral Health and DDHED, they can possibly update the provider manuals and put equal emphasis on actually getting two effective medications that are available in the market for 5 years. And if somebody gets diagnosed, then they should be getting to the next step of treating with the right medications. Because a lot of patients, 40% of them on the wrong medications, even after diagnosis.
Hmm.
That is because, you don't oftentimes correctly diagnose tardive dyskinesia and often misunderstand or misdiagnose for other types of movement disorders because treatments are so different. All other movement disorders may respond to certain type of medications like benztropine or Benadryl or diphenhydramine, but tardive dyskinesia does not respond to those medications. So you need to get particular type of medication called VMAT2 inhibitors. These are the two medications, Ingrezza and Austedo. They are in the market. They are FDA approved to treat tardive dyskinesia. So these things needed to be part of the EMR and algorithms in the treatment settings where you have a TD diagnosis and they will take you automatically to the treatment, just like we do for if we diagnose diabetes, we don't leave them alone, right? So we
Okay.
go to the next step of treating it. The same thing for blood pressure, high blood pressure. So those things need to happen at the payers level, need to happen at CMS and our governmental level, and also at the clinic level where we need to have a clear policies about screening, diagnosis, and the treatment on the right medicine.
If we think about the patient journey, so little of the patient journey is spent in clinical settings. You spend a great deal of your time with family members, potentially caregivers, and of course, patients themselves are concerned with their health. Outside of clinical settings, what should patients and caregivers who are listening to this program should know or ask their providers about TD?
So both patients and caregivers or family members always should discuss with providers about both common and rare side effects and have a true risk-benefit discussion before starting antipsychotic medications. Because antipsychotic medication became so common, they're not used just for psychotic disorders. These are
Mhm.
used for bipolar. They're used for now major depressive disorder. So when you start using for a variety of things, your priority may be different based on which condition you have and your level of risk acceptance. So that's why it's important to have that discussion with the providers. Providers may discuss only common side effects and skip the uncommon ones, either out of time constraints or because they may believe that tardive dyskinesia may not happen to their patient because such a rare thing. They can address it if that happens and if they have a real impairment, so they may put it off. So it's important to kind of be upfront and discuss the providers and see what the risk is before you go on it.
What do you think is the most commonly misunderstood facts about TD?
So for common public, tardive dyskinesia is often misunderstood as this is something patients or people who have a tardive dyskinesia is doing it on purpose. Imagine somebody is traveling in public transportation or in a restaurant, they're sticking the tongue out or they're squinting or they're blinking at people or winking at people or making faces, and people oftentimes misunderstand and take it as a rude, and they even sometimes react to it and then make patients who have these abnormal involuntary movements more embarrassed and humiliated. That would keep them off from public domain completely. So I think if people have more awareness, this may be a neurological condition. This is not like people are doing it on purpose. This is something they're helpless and they need to be more understood and more supported. That way they feel more comfortable when they are around others.
Great. And to end on a hopeful note, what gives you hope when it comes to improving care for people living with TD?
I have a tremendous hope. I've been practicing for 30 years, and as a psychiatrist, we always felt completely hopeless and helpless when our patients had tardive dyskinesia, because we knew about tardive dyskinesia for 70 years, ever since we had antipsychotics from 1950s. We knew it.
Mhm.
We just did not have treatments that were effective until April 2017. So it's been only this long that we had, only 5 to 7 years that we had these medications called VMAT2 inhibitors that are effective. So I am super hopeful because we have finally the medications that work for tardive dyskinesia. And I think now we are fighting the battle, not with finding medications, but a battle in getting people diagnosed and getting people treated and having access to these medications. These two medications are still super expensive, and we have to figure out as a policymakers and governmental bodies and insurance players how to get these medications available to patients, because it's not acceptable to anybody to have only 10% have access to these medications.
Absolutely. Well, we truly are blessed to live in an era with safe and effective treatments for many diseases, including those with TD. Do you have any other closing thoughts that our physician or general population audience, the general population, should know about TD?
I think I think I leave it in a note that I think we should talk more about it. I think we should get the advocacy organizations kind of take this on and educate people who have mental health conditions and take medications. They may not have been aware that they are at risk. So you need a lot of help from every aspect. So we need everybody kind of, help us out to get people diagnosed and treated.
Great. Well, thank you so much, Dr. Katragadda. This has been very informational for me. I know our listeners will find it to be very helpful as we look to help our loved ones, family members, and potentially colleagues who may be affected by TD, and also to expand the base of knowledge in the medical community to recognize TD. So I'd like to thank you again for your leadership and spreading the word. And I want to thank our audience for watching this episode of Top Docs. Please share this program with your colleagues, family, and friends. Remember to follow MAG on Facebook and Twitter. And don't forget that you can get past episodes of the show at mag.org/topdocs. From everyone at MAG, we look forward to catching up with you on our next episode of Top Docs. Thank you so very much.
Thank you, everybody, and have a nice day.
Thanks for watching this episode of Top Docs. Please share this program with your colleagues and family and friends. Remember to follow MAG on Facebook and Twitter. And don't forget that you can get past episodes of the show at mag.org/topdocs. From everybody at MAG, we look forward to catching up with you on our next episode of Top Docs.